Thank you for joining us for Conversations in Advanced Non-Small Cell Lung Cancer, Rationale and Utility of TROP2 Antibody-Drug Conjugates, based on updates from World Conference on Lung Cancer and ESMO. During this segment, we will be discussing the optimizing use of ADCs in different settings of non-small cell lung cancer, as well as a specific focus on toxicity of these drugs. I'm Dr. Aaron Lisberg, thoracic medical oncologist at the University of California, Los Angeles. I'm joined today by my colleagues, Dr. Benjamin Levy and Dr. Alexander Spira. So I think that in this segment, it will be most important for us to really focus on the toxicities. And I know all three of us have had a lot of experience with these drugs. So I think that in terms of toxicities, let's just lead with Dr. Spira in terms of single agent activity, and we'll turn to you, Ben, afterwards in terms of the combos. So with respect to these TROP2 ADCs, what has your general experience been, Alex, with these drugs, and what toxicities have you found particularly difficult to manage?
Yeah, so I think about these as chemo on a stick, and I think it's easy to forget. They're called antibody-drug conjugates. That leaves out the name that there's a chemotherapy warhead at the end. So I kind of think about it as two ones. One is you can have binding of the antibody to a normal cell, and you're going to get side effects from that, as well as leakage or release of the warhead into the general circulation. So, thinking specifically about, let's talk about some of these TROP2 drugs, which we've been talking a lot today. For me, the biggest issue that I've seen in most people, especially with datopotamab deruxtecan, is the mucositis. And while there's a lot of other side effects that I see, the mucositis for me has been a tough one. And it's been tough because it just doesn't happen on day one. It's something that lingers for a week or two, right? So you give people the drug, and then all of a sudden, about a week in, they're having a tough time swallowing, tough time keeping food down. And it's one of those things that gets very annoying in quality of life. They come back in day 18 before the next treatment. They've lost about 2 or 3 pounds. Rinse, lather, repeat. They start doing it again. And, we kind of think of these drugs as people are on for quite some time. Many patients in the phase 1 study were on this for a long time. And what ends up happening is they have continual side effects. Maybe they're on some narcotics for a few days on there. They're having a tough time swallowing. For me, that's the most challenging thing to manage because of it. And, even if you look at the studies, grade 1 or 2 mucositis is not so bad. But if any of us had a grade 1 or grade 2 sore throat for a week or two, 10 days, have every 3 weeks, it gets to be annoying as well, especially when you kind of think about it, well, it's not really chemotherapy. And in my experience, maybe you guys are smarter than me, there's not a lot of things I know that help. We've all tried dexamethasone mouth rinses. My nurses love it. I don't get a long way with it. The ice chips during the infusion, people have tried. I don't get a long way with it as well. So I struggle to manage it for Dato-DXd. I've had a few patients on sacituzumab, and for me, there's a slightly different side effect. I think it's the SN38 analog from the warhead. It's diarrhea. So for me, I've had a few more patients in diarrhea with that drug, and that obviously is very troublesome. Obviously, dehydration, going to the bathroom, a lot of quality of life there. So for me, those are the 2 biggest side effects I think about for those 2 major TROP2 drugs that we either completing studies and will hope to be approved soon.
Excellent. Well, thank you for that answer. And Ben, how has your experience been different? I know you've worked a lot with the combination with immunotherapy. So how has that been the same or different, and how have you managed these toxicities?
I think it's relatively the same, maybe a little bit more pronounced. I agree. I look at these toxicities through the prism through 2 separate prisms. I look at through the prism of traditional chemotherapy. So the normal chemotherapy side effects that we see with other chemotherapies, we're seeing it with these ADCs. I mean, Alex mentioned the diarrhea with sacituzumab govitecan. So you have the GI toxicities, you have the cytopenias, you have the fatigue, you have the alopecia, unfortunately, for many of our patients. And so those are the kind of the traditional ones that we see with ADCs that we also have learned to treat and mitigate with other chemotherapies in the past. The ones that have really are of special interest, and Alex touched on one of these, is the stomatitis. We see that not only with single agent, but unfortunately, we see it in combination with immunotherapy. And getting ahead of that, and some of these mitigation strategies that Alex talking about, the ice chips, the proactive dexamethasone rinse may or may not help. We're getting around. The other 2 things I think that are worth mentioning, again, either as single agent or in combination, or the ocular events that we're seeing. And I think, my experience with this has been with the immunotherapy has been, dry eyes. You can also get increased lacrimation, but dry eyes tends to be the most common thing we see, and we have to partner with our ophthalmologist or optometrist. And then I think, again, importantly, when you start talking either a single agent or in combination with IO, but I think perhaps more important in combination with IO is this drug-related ILD. And so those are the three of the three separate AEs that I think about that are separate from the traditional ones: the stomatitis, the ocular events, and then the ILD. And I think you have to be extremely proactive with ILD. We certainly have had to be proactive with ILD when using ADCs in combination with immunotherapy. We witnessed this in less than 10% of patients when we combine it with IO, but it's still there, and we see it as single agent too. So I think the sort of the comforting news here is that the toxicities, many of them that we're seeing with these ADCs, are those that we see with docetaxel or gemcitabine or pemetrexed or paclitaxel. And we have some understanding, although we may need to get a little bit more sophisticated with managing these with the ADCs. The other ones, the ILD, the ocular events, and the stomatitis are relatively new for us. The ILD, maybe we've learned to deal with this with the IO, but the ocular events and the stomatitis are relatively new. And we are going to have to be extremely proactive when managing these patients. If we want to get them through this journey, then we're going to need to be proactive, and we're going to need to partner with our subspecialists in helping them get through this. I mean, I have a tough time finding the ophthalmologists. Maybe they're all in Virginia, Alex. I don't know. But partnering with our subspecialists are going to be really important for some of these toxicities.
Yeah, I think that your emphasis on being proactive, I think, is really important. And I just want to throw something out to both of you and see what your experience has been. In terms of the mucositis, and then we'll turn to the ILD, when you've dose delayed and dose reduced, what has your experience been? Has that been an effective way to manage the mucositis? Has that, in other words, reduced the patient's symptomatology and potentially allowed them to stay on therapy longer with less side effects? I don't know, Ben, what have you seen with those maneuvers?
Yeah, I think 4 is better than 6 with datopotamab deruxtecan. I have had a favorable experience dose reducing from 6 mg per kg to 4 mg per kg and helping out. Does it work with the stomatitis and some of these other side effects? Also fatigue. Does it work all the time? No. But I do think dose reductions are important. I think starting at 6 mg per kg is fine, but getting ready to go down to 4 mg per kg is going to be important if this drug gets FDA approval and gets put into the clinic. I haven't used sacituzumab govitecan. I know maybe both of you have. I haven't used it, so I don't have a lot of experience with that. But I'm excited to use it if Evoke 1 shows some of the similar trends, if not better, than Tropion-Lung01.
Yeah, and I've had the similar experience with the dose reduction. Again, more experience with Dato for sure. Dose delay and dose reduction. Has that been effective for you as well, Alex, with the mucositis specifically?
Yeah, I mean, I've had luck in dose reducing from 6 to 4. I don't find the dose delays really help very much. They feel better for a week. They can put a few more pounds on, and they're right back where they started from. But I agree with both you, Aaron, and you, Ben, as well.
Yeah, and then
dose reduction to 4 is reasonable.
The follow-up question to that, again, I have my own experience, but I'd be interested to hear both of yours. Maybe, Alex, if you can just answer first. When you've done those dose reductions, potentially in patients that have been on for a while, have you seen a temporal relationship between loss of tumor control at that time point, or have you seen continued good durability of a benefit in patients?
So I don't think I've seen a significant change in response rates or durability. Of course, it's hard to tell as well, right? Typically they've already had a response. You're kind of seeing what's going on. So I don't think I've reduced somebody and then their tumor started to grow. Whether or not that's because 4 is still very active or just the biology of their tumor, for me, it's hard to really tease those two out.
Yeah, that's been my experience as well. Ben, have you seen the same thing, or have you lost control in some of those situations?
No, I think again, dose reduction. I'm not worried about losing tumor control from 6 to 4, at least with the datopotamab deruxtecan. 4 to 2 maybe a little bit different, but I think 4 may be the sweet spot for many of our patients with this drug. Of course, starting at 6, but I haven't had that experience where going down to 4 and all of a sudden there's disease progression everywhere, and there was this temporal relationship with the dose reduction. I haven't seen that in the studies that we've done.
Yeah, and that's been my experience as well. Okay, so let's turn our attention to ILD because I think that's a very important topic for us to discuss about. And then you led with that discussion and talked about, again, being very proactive. What have these, in the patients where you've seen ILD, how have they presented and how is presentation? I mean, especially in the setting of a combination, how do you approach that? There's obviously no way to know which drug is causing, but have you used steroids? Has that been effective?
Yeah, it's a little bit different management. I mean, I think there needs to be this proactive approach with ILD. It has manifested similar to me as an immunotherapy ILD, and it's been new for us with this compound. But my experience has been similar to immunotherapy with a few, at least anecdotal changes in my mind. One is the ILD that I've seen with this has not been this full-blown bilateral pneumonitis that I can sometimes see with IO. It's been more grade 1 or 2, and when I do see it, it tends to be more localized than what we see with immunotherapy. And I don't think this has been recapitulated in the literature, but that's certainly been my experience. That's number one. Two is I think that steroids are the way to go here, and that's what I've used and have been successful in that. Again, I don't have many patients with ILD with this drug. I have to remember with datapotamab deruxtecan, the ILD rate was quite low in TROPION-Lung01, and the study that we did, even in combination with IO, I didn't see it that much. I think the real important part of ILD management is you really got to be proactive. You got to screen the patient. You got to talk to them, see how they're doing, scan them, suspend the treatment, and then implement the steroids. And we need to remember the algorithm for the treatment or the suspension of ADCs for ILD is different than the algorithm for the suspension of immunotherapy with ILD. For a grade 1 a patient on immunotherapy getting a grade 1 pneumonitis, you can continue IO. For grade 1, at least for now, for ADCs, the recommendation is to hold the treatment. So there's a little bit different nuance here. That may change over time, but that's where we are right now.
Yeah, and that's a good point. In the grade 1 cases that you've seen, if you've seen this scenario where you've started steroids, have you been able to have radiologic resolution? Have you re-challenged? What's happened in that setting? Do you have any?
Yeah, we have. I mean, I've only had a few, but yes, these ILDs were steroid responsive with resolution where we were able to re-challenge them.
And did it recur or?
No, not in the ones that we had.
Alex, what has your experience been with ILD more in the monotherapy setting?
So this is one of the few things that scares me. And as I said, and the main reason being is, especially after participating in the phase 1 where we pushed it to 10. And, 8 to 10, the ILD incidence went up and I had a couple of bad cases there. And the reason it scares me is, it's hard to pick up, right? I mean, I'm a lung cancer patient, I have increasing cough and a little bit more shorter breath. We're trying not to scan these people every week, right? So you're trying to make a clinical diagnosis. Is it a viral infection? Do I need to get a scan? Is what's going on? So it's often very hard to make the diagnosis. And grade 1 ILD/pneumonitis, whatever you want to call it, is a radiographic finding. And we've all looked at scan reports. In fact, we've all looked at scans. And, the radiologist in point number 9 says, small hazy infiltrate at the right lower lobe, and you blow it off. That could be a sign of early ILD pneumonitis. It was technically grade 1. We're supposed to hold. So think about how hard it's going to be to manage. And then if you're only scanning people in the real world, it's cycle 4, you're not scanning them to cycle 7, and they're going on vacation. A long while can go by. Things will get bad in a hurry. So it's one of those things that make me nervous. And we've all taken care of ILD patients on other drugs or maybe an ADC where they just don't get better. And you go from that point where they have like a pneumonitis-like picture where they respond to a point where they don't respond. And they're stuck with a fibrotic lung and they never get better. It's rare, especially with the doses what they're using, but it's really hard to make a diagnosis sometimes in our patients who have a lot of other reasons to have a cough and shortness of breath. Is it post-obstructive atelectasis? Is that what's causing this infiltrate, or is it pneumonitis? And right, it's easy to be wrong, and it's a very humbling. For me, it's a very humbling time for mistakes that I've made when you're not sure what to do.
Yeah, I think those are really excellent points. Okay, so to wrap up this, I think I'll ask a final question, and maybe start with you, Alex. On a whole, given your experience and with reviewing the data in terms of these TROP2 ADCs, we definitely have just spent a long time talking about the unique toxicities. But on a whole, would you say these drugs are more or less well tolerated than our standard of care second-line docetaxel?
So the easy answer is I'm not a docetaxel fan. It's been around for a long time. One we all want to change, but I do think it's easier. And docetaxel, in my clinical experience, is a tough drug to give. I usually limit it to 6 cycles. I've been able to give data for up to a year or more. No alopecia. And docetaxel in real world has a lot of side effects that are probably very similar that we're just undercalling it. And I always kid people, I wonder if docetaxel was going up for FDA approval today, would it have made it? Because of all the side effects and the tolerability, et cetera. And my bet is it would have probably been a negative study for whatever you were comparing it to, and they probably would have said, go back to the drawing board. So I think, assuming these get approved, it's a big step forward.
Okay, excellent. And Ben, final thoughts on that point?
Yeah, I would agree. I think it's a step forward with the second line therapy. I mean, going to your study, Aaron, the Tropion-Lung-01, we need to remember, yes, there was stomatitis and yes, there was ILD, but there were more dose reductions in the docetaxel. There were more dose continuations with docetaxel. So there were more serious treatment-related adverse events with docetaxel. So, I mean, I think the data speaks for itself. We need to get proactive with management of some of these unique side effects, but I think this will be a step forward. Is it a huge step forward, or is it just kind of a baby step? Maybe at this point, I'll take a baby step. And so I'm happy with that, and we'll see.
Okay, excellent. Well, thank you both. And thank you again for joining us for this segment on optimizing the use of ADCs in different settings of non-small cell lung cancer with a specific focus on the toxicity profiles. Please be sure to click on the landing page for this activity to claim your continuing education credit, access supplemental slides, as well as other topic segments.